Ladies and gentlemen, we will start shortly. So kindly ensure that your microphone is turned off so that there will be no disruptions to the session. Thank you.
And the video also counts.
Right, everyone, we'll begin the webinar now. Ladies and gentlemen, a very good morning. I am Dr. Yao Mei Chen, and I am a lecturer from the School of Pharmacy, Faculty of Health and Medical Sciences, Taylor's University, and I will be your moderator today. So thank you for joining the webinar. And with the COVID-19 vaccination program for children aged 5 to 11 still ongoing in Malaysia, we would like to take this opportunity to listen from two experts on the efficacy and safety of the vaccine in children, as well as how the Ministry of Health monitors for adverse effects following immunization. We also have Ms. Rebecca Fong with us here today as a Malaysian Sign Language interpreter. Next slide. So before we begin, please take note of the following housekeeping rules. Please keep your mic muted throughout the whole session. You may type your questions in the chat box should you have any questions, and the Q&A session will be held at the end of the webinar. Next slide. So this is the webinar agenda. So we will start with a talk from Dato Dr. Amar-Singh and then proceed to Dr. Azuana Ramli. We will then have the Q&A session at the end of the webinar. So throughout the whole session, if you have any questions, please type them in the chat box and your questions will be answered by the speakers at the end of the webinar. Next slide. So without further ado, let me introduce our first speaker. Dato Dr. Amar-Singh is a senior consultant pediatrician. He served the Malaysian Civil Service for more than 35 years and led both a regional pediatric department and a clinical research center. He has a long-standing interest in children. He has assisted the Ministry of Health to revise the child healthcare services and introduce a number of national programs for children. He is an active child advocate and is the recipient of the Outstanding Asian Pediatrician Award 2012 and Senior Advocacy Award 2016. He has established a number of NGOs and family support groups. He is also a senior fellow at the Gallant Center for Health and Social Policy. Dr. Amar, you may now share your slides.
Thank you very much, May, for that kind introduction, and I'm delighted to be here with Rebecca doing sign language as well. In advance, I'd like to convey Ramadan blessings to any of you who are starting your Ramadan fast tomorrow. Thank you for Peggy and Renuka from School of Pharmacy, Taylor's College for this kind invitation, and thank you for your excellent organization throughout. Allow me to share my slides and let's get going. All right. Just get a proper spotlight. Okay, yeah. Can see those slides, May?
Yes.
Okay, all right. So I've been asked to talk about current trends in COVID among children and should we vaccinate our children. And I'm going to focus a lot on the 5 to 11-year-old children. These are the kind of questions I'm going to answer. As I answer them, I want to answer them available from the best data that we have currently, not rumors. One of the problems that we have in Malaysia is a lot of WhatsApp and Telegram rumors which damage our understanding of this. I'm going to answer from available science and data, and I'm going to try and use the big picture and then come down, scale down to Malaysian picture. So I want to ask a question: are things getting better? Is the end in sight? You know, what are our possible futures for COVID? What is happening to Malaysia children right now? Is Omicron mild for them? What are our complications and what outcomes can we expect from COVID-19, including for our children? And then finally focus on the vaccination program and suggestions for children, especially 5 to 11, but also younger and older children. So let's start about, are things getting better? You know, is the end in sight or not? All right. So here's the Omicron wave for the whole world. And you can see compared to anything else before, the Omicron wave was huge compared to what's gone before. So although people say it's mild, it's actually milder. It's not really mild as much. And here's deaths. Those were cases. Now we're looking at deaths. And you can see generally it's not as huge as the previous waves, but still quite considerable. Knowing, of course, at this point, more than 50% of the world is vaccinated. So we have this downhill death curve, mainly because of a sizable amount of vaccination. Having said that, the real number of deaths is a small shadow of the total deaths estimated in the world. The reported deaths is much smaller. That applies to Malaysia as well. So here's Malaysia. We can see we have a huge Omicron wave. Hospital admissions also went up, but fortunately our ICU admissions and our deaths didn't go up as much, but they were there as well. And as I said, we have reported about 35,000 plus deaths, but the real estimate is another probably 18 to 20,000 deaths that were underreported in our country, partly due to the way we define our deaths. We're not doing that well with our vaccination. Getting there, but not as good as many other countries, and we use a mixture of vaccines. I've prepared a paper for the Majlis Pemilihan Negara, which we're going to present very soon to them about education. I thought I'd show you one slide from that presentation and focus here, and that's Malaysia here. We will have one of the worst learning outcomes in this last 2 years, and that's showing you the impact of this whole pandemic on our children. In fact, only Myanmar is worse than us in this time in terms of learning loss that our children have suffered. So obviously, this pandemic has serious consequences for our children as well as for the rest of us. So what are the possible COVID futures that we're going to face? It's extremely difficult to predict. Anyone who thinks that things are fine. We have declared endemic a number of times in different countries. Even last October, we talked about endemic, but you know, here we are again. I think it depends on, you know, how much death we are willing to accept, how much hospitalization, disruption of our healthcare services. Are we going to get a new variant that's resistant? Can we develop better vaccines and vaccines that hit all variants and all coronavirus? Can we develop better drugs? And most importantly, perhaps, what's our behavior like as people in Malaysia? So I want to start off by saying, regarding this whole movement that we are, yesterday we declared endemic and we are moving towards endemic, but endemic is not equal to good or better. And the endemic is not equal to mild. These are WHO statements. So some people have coined this word pretend endemic. That means we're going into an endemic phase, but actually it may not be actually a true endemic. Here's some here's some idea what we're thinking about. We would like this kind of a situation where each wave gets smaller and smaller, and we go to a low-grade situation where it's like influenza, a background disease with some deaths and disease and admissions. But WHO has warned that the next variant of concern that comes after Omicron probably will be more infectious and may not respond very well to vaccines. And WHO is usually very conservative. For them to say this means that they are concerned. Okay, so this is what may happen. Instead of going down, we may have a huge spike. I'm talking here about hospitalization, not cases. We're less worried about cases, although there's some concern with cases as well. So if this happens, will we go back to square one if this new variant, evades our vaccine? And that is the big concern that we have with moving to a so-called endemic situation. Here are some examples of people who countries that attempted to go to endemic. In Denmark, restrictions were removed in February. And see here, I'm looking at deaths per population. And you can see this huge death thing. They never had that volume of deaths before. And they moved to endemic. They removed the need for almost all things, including masks and social distancing. And they are pretty well vaccinated, far better than us, and mainly Pfizer. Testing, of course, was reduced. So this spike may have been greater. Here's South Korea in green. I've left Denmark there and added South Korea. And they had restrictions eased due to elections. And again, they had a huge spike. They never had this volume of deaths before. So huge spike of deaths again. Again, much better vaccinated than us and boosted using a variety of vaccines. At the height of this outbreak, they had 600,000 cases a day. And South Korea is very good with testing. So we know the numbers are more reliable than many other countries. So we say we want to move to endemic, but perhaps what we think of endemic and what the reality may happen may not be the same. Okay. Here's a nice graph drawn by using our World data, showing that almost every 130, 140 days, we have a new major variant of concern. The Gamma wasn't a big deal, but the others are all fairly reliable. And they believe in April, we have another one. But for us, I think in Malaysia, what we will have in April right now is a BA2, the Omicron changed variant, which will probably spike enormously at that time. So is the end in sight? What is the future for us? The reality is that COVID is here to stay. It's going to be here a very, very long time. Some people even suggesting that our grandchildren will be vaccinated as well, just like influenza. And many of us will have the risk of getting infected over time, even though we are vaccinated. Some maybe infected a few times. Thank God for vaccines, which have improved the outcome for death and hospitalization, but this is current and we do not know the future. All right. So what's happening to children in Malaysia? Is Omicron mild in them? And what kind of complications and outcomes can we expect? I'll take this together, all right? So here's children. The one in orange or yellow is 0 to 4, and the one in gray is 5 to 11, where I'm focusing. And you can see we've never had such big waves as the current Omicron. Of course, we had Omicron plus Delta in this wave. And why did our wave come down? Because of school holidays. Because a lot of data from the UK and other countries showing that school holidays drops these waves, both for adults as well as children. So we can anticipate that there's going to be a BA2 wave in our children and adults, probably starting in April and then picking up probably the end of April. Remember that all these cases that we're showing is despite poorer testing that our country is doing right now. So the real peak is much higher than this. So obviously our children are being impacted now. They weren't so badly impacted earlier in the pandemic, but now it seems this highly infectious strain has damaged them more. Is Omicron milder? Is Omicron variant milder? If you look at UK study that came out in February, they said that for children under 10, Omicron is just the same as Delta, and Delta wasn't very nice variant. In the US, 1/3 of all the child deaths that they had occurred during the Omicron surge. So the huge volume of effectiveness also adds to more deaths. And here's a recent Hong Kong study just come out in March, showing that the BA2 variant is more severe in the non-vaccinated children than previous strains. Higher rates of ICU admissions, more damage to your brain. Neuropathic means to your brain. So they're not happy with the BA2 strain that's happening in Hong Kong. And some of you would have seen the Hong Kong data and the huge surge they had there. So what's going to be our complications and outcome? You are familiar with number one, which I've been talking about, which is admission, death rates, and organ damage. But there's the intermediate effect of COVID, which is the long COVID, which many of you, I hope, have read enough about. But there's one that you're not thinking about, which is the long-term burden of COVID. And let me share some ideas about this using our own data. Okay, but here's a schematic describing that. So you may have an asymptomatic infection or acute infection and you recover well, or you may have infection that leads you to hospitalization, may recover, or you may die, or you may get some damage, okay, to your organs and end up with chronic ill health for a while, and some die further down the road. That's why they're not classified as COVID. And there's also long COVID, which may last up to a year in many individuals. Of course, thankfully for many, it lasts only a couple of months. And then there's this long-term impact of COVID, which we may see presenting now and going on for maybe decades. And these two, long COVID and the long-term impacts of COVID, are not related to severity alone. Asymptomatic mild infections can also end up in this situation. So what's happening in Malaysia with, almost 0.75 million children infected, I'll show admission ICU in a moment, a lot of multi-system inflammatory disease in children and some deaths. Okay, let me look at all of that. So here's our admissions for children going up, and our ICU admissions have been going up in this recent way. And we can expect with BA2 that this will be another spike that we are going to face. So this recent outbreak has not been good for our children with hospitalization. Here's MISC data for up to December, and it showed 174 children getting this very severe form of COVID, inflammatory condition that happens after the COVID infection passes away. Your body is attacking itself. And notice that a sizable number, the vast majority, were in young children. And if you include all of this, the majority were actually under 11 in this age group. And that's the age group to worry about. Okay. What about deaths? Here's comparing October to December deaths and versus January to March deaths. The dark brown is 0 to 4. The orange is 5 to 11, and this lighter pinkish color is 12 to 17. And you can see deaths have gone up. They've gone up especially for the very young children and the 5 to 11. Why? Because these are the less vaccinated, no vaccination or less vaccinated. And the adolescents who have some vaccination have protection. So our deaths actually have gone up, not come down recently in children. Okay. If you look at the death rates, you can see this difference in death rate, and the well-vaccinated adolescents have a very much lower death rate than the young children. And these are partially vaccinated children, so the death rate is in between. So if you're not vaccinated, your death rate in children may be 4 or 5 times that of the vaccinated children. So I've talked about the immediate quite a bit. Let's look a bit at long COVID and long-term burden of COVID and what do we know. We don't have much data locally, so I'm going to use some international data. For adults, 30% at least, 20-30% get long COVID, good data on that. And if you are vaccinated, the risk drops by 50%, but still you have about a 9 to 14% risk if you, even though vaccinated, if you get a breakthrough infection, you might still get long COVID. Less severe, good data from Israel and France showing less severe, but still going to happen. Here's UK data showing that 1 to 2% of all the children have had long COVID, and some of them last for 1 year. 20,000 children have been living with long COVID for 1 year. And what does long COVID really look like? Here's an example, a personal example from a doctor, a consultant physician, respiratory physician in UK. Here's a daughter, Jasmine, 10 years old. Here's what she used to look like, and here's what she looks like now with long COVID. She has difficulty walking, she needs a wheelchair. And that's what long COVID can look like for some children. So it's not a pleasant disease to have. Okay. A recent study looking at 21 different studies from many parts of the world, comprising 80,000 children with coronavirus, 25% developed long COVID, mood symptoms, fatigue, sleep disorders, headache, respiratory symptoms long term. So it's much higher than the UK data. So what about this long-term burden that I talked about? The long-term burden covers something that's more sinister, more worrying long-term, and even mild cases. This is damage to your organs, to your brain, to your endocrine organs, causing diabetes, to your heart, and to your kidneys, and so on. And it doesn't seem to be related entirely to severity. There are quite a lot of studies right now. I just listed a few here. We know that we are having problems with our children right now with the mental health pandemic and their school development and so on. But this one is showing that heart, brain, lungs, endocrine organs have damage, subtle damage even at 12 months. And look at the rate of that for people who are infected. Very, very high, isn't it? So people are now postulating for what happened during the 1900s influenza outbreak, where there's an increase in dementia risk long-term. We believe that COVID also may lead to this long-term, especially since there is a brain damage that we're seeing. We also estimate that disability rates are going to go up and be a sizable proportion of the burden of COVID. So I'd like you to keep an eye on this long-term burden of COVID, which is something that you should consider when you're thinking about vaccinating children. So again, I want to stress that neither long COVID or long-term impact COVID are necessarily related to severity. They can occur in asymptomatic or mild infections. So what's happening to our vaccination program? Are the vaccines working? Who should we vaccinate and so on. So here's comparing the adolescent vaccine program, which is very good, more than 90% vaccinated, with the young children 5 to 11 vaccination program, where only 37% have received 1 dose. And I'm very worried about this one. Many pediatricians are very worried about this one because we have priority groups inside there. And MOH has outlined the priority groups: anybody with a chronic illness, anybody with a disability, anybody who's immune compromised. All the children are much higher risk. And we're worried that these priority groups have not got their vaccine to protect them, not to mention the rest of the children that I talked about earlier. Looking by state, you can see that Sarawak has done the best. The other states are not doing well. And some data from COVID now shows that there seems to be an ethnic bias and there's a higher uptake among the Chinese community in our country. Okay. There are 2 vaccines currently available to parents. There's the Pfizer vaccine, I'm going to use that name, and the Sinovac vaccine. And for children 5 to 11, the dose is 1/3 the dose, okay, using the available studies that are available. And Ministry of Health has made a decision to give it 8 weeks apart. This is a very good decision because it reduces the side effect risk doing this and improves the immunity of this vaccination. Okay, and so you got to be aware of the different kinds of colors and so on. So when you go to get vaccinated as a parent, I think you got to keep an eye on this as well, because somebody may choose the higher dose one, and we don't want that for our young children. Okay, for Sinovac, which is inactivated virus vaccine, we are using 2 doses 4 weeks apart. We're using the same dose as an adult. Okay, now the Ministry of Health guidelines for this is children who cannot receive the Pfizer vaccine, parents who don't agree, and children without any underlying comorbidity. That means if you have a chronic disease, you have a disabled, you're immune compromised, they prefer you getting Pfizer. In fact, that is the preferred vaccine by the Ministry of Health, and Sinovac is a backup. What's the reason for this decision to include Sinovac? Many of us have been wondering about that. Why do I wonder? Because Sinovac has never published phase 3 good study data that we want to look at. So there's not that much data on Sinovac. There's enormous data on Pfizer, both for adults as well as children. So we know what to expect here. We don't know here. So we suspect that Ministry of Health has agreed to this because of pressure. Vaccination rates are not going so well, as I mentioned. So they want to push that, and they want to give an option to parents. But recognize this is with reluctance, both by Ministry of Health and also pediatricians. We're not so happy to use this vaccine when the data is not so clear. Okay. Somebody asked this question before the talk, so I thought I'll show up this slide. This is just looking from our own data at death rates. The red bar is unvaccinated, the gray bar is fully vaccinated 2 dose, and the blue bar, the dark blue bar, is boosted. And you can see that adults who are not vaccinated are 3 to 4 times more likely to die. And this would apply to younger age groups as well. So what is the data for Pfizer and Sinovac in terms of protectivity for different things? This is Pfizer protection, real world data, not just the studies for the clinical trials, but real world data, looking at Omicron infection, 2-dose vaccine, and that's about the protection. Not terribly great. This is protecting you from getting an infection. Better in adolescents, probably because the dose is higher there. And here's the more important data. Does it prevent the child from getting hospitalized? And this is the range, 73 to 94%. For 5 to 11 years old, it's about 74% protection, which is pretty decent. We're likely to be higher. Again, it's higher for the older children because of the higher dose we're using. Right? What about Sinovac? As I said, no phase 3 trials. 1 Malaysian randomized control trial for 3 to 11-year-olds. Results should be out soon. Our colleagues are getting that. They're analyzing the results right now. And also, I want to point out that I have limited data on side effects for Sinovac. There's this study that's just come out, thank God, from Chile. A large number of children they looked at, but notice that this age group is 3 to 5, not 5 to 11. They use a 2-dose schedule, 4 weeks apart, and the infection protection wasn't that great, again about 38%, hospital protection about 64, 65%, and intensive care admission about 79%. Unfortunately, they did not give us any side effect data in this study to look at. I want to show this study, which is from adults in Sinovac, Sinovac and Pfizer. I want to show this from data from Hong Kong, despite adults, because if you look at 2 doses of Sinovac in light blue and Pfizer in dark blue, you can see this gap, worse in the first dose, some improvement second dose. So basically, if you take a 2-dose Sinovac in those above 60, you don't protect as well. There's a 12 to 70%, increased deaths in this group compared to this group. Once you take 3 doses, the difference is disappeared. Huh? Now, this is adults. We don't know enough in children, but you can assume that the immunity is going to be similar to some degree. Are the vaccines safe? Okay, I'm not going to go through this one, but I'd like to mention this excellent study that's come out from the UK. Dr. Azuana will deal with safety extensively and side effects extensively, so I will go this very briefly. But this study from UK is very good. What they did was they took people who are aged 12 to 19 who had received a vaccine and followed them up for 6 weeks. At the same time, they took people who had COVID infection and followed them up for 6 weeks. And here's the results we'd like to show you. So this one up here is people who had vaccination. This 6 weeks after the vaccination. And here are people who had an infection, okay? And you can see there is no impact on death, no impact on cardiac death. I think this is in the mind of many parents. They're very worried that COVID leads to cardiac death. COVID vaccination leads to cardiac death. But this very, very good study, large one from the UK, following up many people for a couple of months, 6 weeks after that, that there is no increased cardiac death, no increased overall death. But if you get a COVID infection, you have a 6 times increased death, cardiac death, and a 4 times increased all-cause death. Huh? So I want to assure you that this kind of good work that comes up from UK showed that the vaccination has not increased death in this age group. Remember, this age group is 12 to 29 years of age. So here's a summary for you. I know I showed a lot of data. Here's the kind of summary that you need to see. Remember that this data applies for Pfizer for 5 to 11 and Sinovac for 3 to 5. I wish I could get same data, but we don't have that data. And to prevent infection, 31 here, 38 here. Prevent hospitalization, 74 here, 65 here, percent here. And the side effects, Azuana will deal with this more, but the highest side effect at this age group that I worry about is myocarditis, which is about 2 per million for girls and 4 per million for boys after the second dose. Again, this will be grossly reduced if we follow our 8-week schedule which we're doing in Malaysia. I cannot answer this question for Sinovac because there's no real good international surveillance that I've seen, unlike other countries which have been following up Pfizer extensively. I wish China, Indonesia, and other countries, Chile, published this data for us to look at. I've shown this slide before in other talks, but I think it's worth showing again. This is what you are worried about, this small dot here, deaths due to vaccines. Is it possible to happen? Yeah, I think it's possible to happen. It's extremely rare. I don't know what the rate is, 1 in a million, 1 in 2, 3 million. Yeah, it's possible. This is the this bigger dot here, this red dot here, is side effects due to vaccine. And as I told you, severe side effects due to allergy is 1 per 100,000, but myocarditis 4 per million. So not very big, but this is what we should worry about in terms of side effects. And here's death due to COVID, which is, sizable. And here's death due to other reasons because healthcare is damaged due to COVID, called collateral deaths. And here's long COVID, which is much bigger. And of course, the huge disruption to our lives due to COVID restrictions. And finally, there's long-term COVID, which we're just barely beginning to understand. So always when you hear rumors or hear things, think about the big picture. This is the one that, these two are the ones that you're worried about. But we are worried about all these other things which are impacting our children and adults. Okay. Let me answer 1 or 2 quick questions that you may have in your mind. Do children need a booster? US has started boosters for adolescents 12 to 17. They don't recommend boosters for under 12. They especially say you need a booster for people who got immune compromised or chronic diseases, and they recommend 5 months after the first 2 doses. The European CDC, Center for Disease Control, says there is no evidence right now that immunity is waning to damage hospitalization. You may get infected, but you may not hospitalize, so they don't recommend it. WHO says, again, there's no evidence right now for healthy children to need booster. Remember, this is healthy children. So I think you should think about boosters for high-risk children, immune-compromised, chronic disease, disability. Do these children need boosters? I think we need to consider that. And I think we'll have to ask MOH to consider this as we go along, and we need good data on this. And these are children who may need a booster down the road for children. Do we need a yearly booster for at-risk people? I do not know. The question is still too early to answer this, but this may come our way. If we can't produce better vaccines, at-risk people, elderly, chronic disease individuals might take like an influenza-like booster once a year. But I don't think this is going to be for the rest of us who are healthy. Should we vaccinate our 0 to 5? Right now, the studies haven't shown enough benefit for Pfizer, partly because they use a very small dose. They reduce the dose each time they use in a lower age group. And so currently the immune response was okay, but the protection wasn't good enough. So there's no recommendation right now for 0 to 5. So I can't offer you anything for this age group. Sinovac, of course, has been going down to age 3, but I've not seen the phase 3 data, only the recent Chile data for this. But MOH has not accepted this as yet. I want to recommend that you look at this guidance. Always go to KKM site. They're very good. The Ministry of Health site has a lot of documents. One of them is the clinical guidance for vaccination for children 5 to 11 years. And one question many parents ask, including some of you here, how long does a child need to wait before receive COVID vaccine after infection? So you got a COVID infection, you want to vaccinate your child, how long should you wait? And here's the MOH answer. The moment your child is well, you can go and meet. You can go ahead and get the vaccination. I would suggest as a pediatrician, you wait about 2 weeks. The virus usually washes out after about 10 days. So 2 weeks is good, and then go. Some people suggest you wait a little bit longer because when you make your child is completely well, you have no long COVID features. Otherwise, you may confuse the symptoms that come later with the vaccination, but may have actually come from the infection. But generally, the guidance is 2 weeks, you can go ahead and vaccinate. What about how to monitor my child after vaccination? The main side effect we're worried about is myocarditis. Again, this comes from this same document I mentioned. It's the last page. I would recommend that you actually print it and keep it accessible to you, show it to your doctor if you're worried. And these are the symptoms that are recommended if your child has chest pain, is breathless, breathing fast, the heart is beating fast, they look fatigued, very tired, they're fainting, they've got a lot of vomiting, they're low-grade fever. Okay, some of these symptoms. Again, many of these are in the first week, usually after the 4th or 5th day that myocarditis starts to develop. If you got the symptoms, go and see a good doctor, get ECG and some heart enzymes to test and looking for evidence of myocarditis. Right? So keep an eye on this as guidance for you what to do. All the other side effects I will leave to Dr. Azuana to discuss. I want to end by saying 1 or 2 things to you. One is please use a mask. No matter whenever people say don't use mask, use a mask. You go to Ramadan Bazaar, use a mask. Go to Pasar Malam, use a mask. Outdoor also use a mask, not just indoor. But use a reliable FFP2 or KF94 mask. The good cloth mask and surgical mask are only 60 to 75% effective. And I would move to a KF94 mask, but reliable. Many of the ones bought online are not reliable. Go and find a reliable manufacturer and buy from them. Okay. Secondly, fixed ventilation. Fixed ventilation in the schools for your children, the kindergartens and nursery. Look at what Taiwan is doing. They've got a HEPA filter in the bus. They've got, this is Australia, they've got a HEPA filter next to every hospital bed. And we need to do this. We haven't fixed our ventilation in our country, and that's not keeping our children safe. Okay. So in summary, you're going to ask me this question, should we vaccinate our children? I think yes, because it improves the safety of our children, especially now that the country is opening up, and I'm worried about this. People are going to move around, tourism is going to boom, we're going to have a lot of mixing, school has opened, all that is going to put your child at higher risk to improve safety. It reduces death and serious illness, reduces risk of long COVID, and it's going to reduce the risk of long-term impacts of COVID on your child. There are other benefits, but I think these are bigger benefits to society, less to your child, which is your child less likely to bring back COVID to the family and to other members of society. And of course, if children get less COVID, there are less new variants to develop, which is important. Here's the Malaysian Pediatric Association survey. My peers, pediatricians, asking, are you in favor of vaccinating children 5 to 11? More than 200 pediatricians respond and 98% said yes. And they suggested mRNA as the major vaccine to use. Some suggested Sinovac, some suggested other vaccine. Don't use this suggestion, adenovirus, because it's not a good suggestion. I think the AstraZeneca one is not a good vaccine to use children, not enough data there. So the majority suggest you use Sinovac, and more importantly, the majority said, please get your 5 to 11-year-olds vaccinated. So if you don't trust anyone, trust the Malaysian Pediatric Association. We have no ulterior motive here in vaccinating you. Finally, I want to say the most important children that we must vaccinate 5 to 11 and older is the children who are vulnerable. And who are they? The children with disabilities, as I mentioned, the children who are immune compromised and chronic illness. And think of our under 5, we must reduce the spread of COVID to protect them. Right now, they have a high risk of death and MISC in them, and we need to reduce COVID reaching them. There's only 2 we have right now. That works by vaccinating everybody else and using good masks and ventilation. So please vaccinate your children. Thank you very much for listening to me. Back to you, May.
All right. Thank you for the very insightful talk, Amar. So participants, if you have any questions for Dr. Amar, please put them in the chat box and we'll address them at the end of the webinar. All right, we will now move to Dr. Azuana. Let me introduce Dr. Azuana. So Dr. Azuana Ramli has a vast experience as a pharmacist from serving in the community, hospital, and drug distribution. She was also posted to the Pharmacoeconomics Unit at the Pharmacy Practice and Development Division, Ministry of Health, MOH, overseeing the review and selection of medicines for the MOH formulary. Upon the completion of her PhD, she moved to the Pharmacy Policy and Strategic Planning Division, MOH, as the Deputy Director for Pharmacy Research. Her main responsibility was to plan and execute research activities in supporting plans and policies for the Pharmaceutical Services Program. Currently, she is working as the Head of Pharmacovigilance Section at the National Pharmaceutical Regulatory Agency, NPRA, managing pharmacovigilance activities for medicines and vaccines at the national level. She was also heavily involved in the preliminary works tasked to NPRA for the timely access to safe, effective, and of quality COVID-19 vaccines in our country. Dr. Azuana, you may now share your slides. So let us now welcome Dr. Azuana Ramli with a talk on adverse effects following COVID-19 vaccination in children, Malaysia's experience. Dr. Azuana, the floor is now yours.
Right. Thank you, Ms. Yao. Can you all see my screen?
Yes.
You hold on because I cannot move the slides. Okay, thank you, May, again for that kind introduction. Assalamualaikum warahmatullahi wabarakatuh, and salam sejahtera, and a very good morning to everyone present here today. And also thank you to the School of Pharmacy at Taylor's University for inviting me to share some information on the safety and risk of vaccine COVID-19. And I know some of us parents are still undecided on whether to bring our children for COVID-19 vaccination or otherwise. So hopefully our discussion today will help to clarify some doubts that you may have and enable us to make an informed decision. So since I do not have much time, this will be my presentation outline. First, I will talk about the NPRA rules, the regulatory authority rules in medicines and vaccine safety. I will discuss a little bit on pre-registration and post-registration, which include pharmacovigilance. And then I will move on to discuss a little bit on how we do the AEFI monitoring, the process, the reporting process, investigation, the assessment, and as well as how to report AEFI. And then I'll move on to share some statistics on the real world data, the local data on vaccine, AEFI of COVID-19 vaccines. Right. So in Malaysia, similar to the United States, FDA, EMA in Europe, we have NPRA, which is the regulatory body which is responsible for ensuring the quality, safety, and efficacy of our vaccines as well as other medicines in Malaysia. So how this is done is it's done through the process of product registration and licensing, which has been in place since 1985, and NPRA is also a collaborating center for regulatory control since 1996. Right. So it is important for us to be aware that medicines and vaccines, including COVID-19 vaccines that are released in our market for use, have undergone rigorous steps in their development life cycles, as you can see at the top of my slide there. These include three phases of clinical trials, and then we have regulatory review before they are approved and launched. And then for regulatory review, we have evaluators in NPRA that evaluate the evidence that we have to ensure that the products, the vaccines are really efficacious, safe, and of quality before they are approved by our Drug Control Authority or PPKG. And at the same time, once a medicine is approved for registration, NPRA also has the post-registration functions where we still monitor the safety and pharmacovigilance of the medicines. So here in this slide, I just want to share that even the companies have their commitments for us for Malaysia. One, in safety monitoring. So one, before pre-registration, pre-registration, they have to, and we ensure then that we ensure that this company are fit to conduct pharmacovigilance and safety monitoring. So at the same time, these companies also are required to send us their risk management plan based on the risk that they know about the vaccines in clinical trials. For example, I want to give an example. For example, things like side effects, which is anaphylaxis. This was known. I mean, this was detected during clinical trials. So in one of the risk management plan that they propose is all vaccinees or vaccine recipients need to be observed at the PPVs before they are released. I mean, they are allowed to go back. So that was one of the risk management plan based on the risk identified in clinical trials. So the companies also have post-registration commitments, usually stated as their condition for registrations, whereby post-registration they will need to submit monthly summary report to us, and then they also need to notify us on emerging safety issues. This is to ensure that the safety of the vaccines continuously monitored even post-registration. So NPRA rules in regulating the safety can be summarized in this framework here. We have a look at pre-registration activities on the on the left side here, and then as well as the commitments of the companies post-registration. And NPRA itself has its commitment to conduct post-registration pharmacovigilance, which we see on the right side here. All reports are received through various platforms, as you can see, and I will explain later. When we receive the reports, then the monitoring will start. Right. I will come back in a minute on the reporting. So first, allow me to properly define what is AEFI. I think this is very important because sometimes we hear that people report that they have AEFI. So we need to know whether these are actually AEFI or otherwise. So AEFI, per definition, is any untoward medical occurrence which follows immunization, and which does not necessarily have a causal relationship with the usage of the vaccine. That is very important. So AEFI at the bottom there can be classified based on the cause of the event, apart from the vaccine itself or the ingredients in it, or even the quality of the vaccines being the cause of the AEFI. Some AEFIs may be anxiety or stress related due to immunization process, or may just be coincidental occurrences. So the actual cause could be the recipient's underlying diseases or even new illness being first identified. Therefore, any AEFI reported needs to be evaluated first to rule out such possibility. So this is, as I mentioned earlier, this is an important information because we will get information from social media, people saying that they have AEFI. So it's important to understand that it may not be AEFI. It can be coincidental, right? So now let's move on to how the reports get processed. What are the steps involved? So reports are received through the various platforms from public and private healthcare facilities. These reports are screened, cleaned. If additional information is required, we will contact the reporters, coded and entered to the ADR monitoring center in NPRA. And then the reports are categorized to serious and non-serious. So definition of serious events will be reactions or effect that requires hospitalizations or prolongation of existing hospitalization, cause persistent or significant disability, birth defect, or could be life-threatening or could result in death. But the serious effects that we normally receive is those ones which requires hospitalizations. So for serious reports that need further investigations, for example, death reports, facilities will be notified to actually form an investigation team. They can form it at the district level or at the state or health office level. So they need to fill in an investigation report form, which they need to submit to NPRA. So these reports will be presented in a special committee we call JFK, which is Jawatan Kuasa Pharmacovigilance Khas for COVID-19 vaccines, which the members consist of specialists and consultants from various disciplines like cardiology, immunology, infectious diseases, nephrology, paediatrician, even forensics, and so on. And then they will discuss, and this is the committee which determines the actual causality of the serious report. And then later on, all of these reports will be collated and then indexed, and we have the responsibility to send it back to the PRH as well as the facilities that report, as well as we share our information with the WHO global database as well. All right. So now I will move on to, I will share some of the statistics that we have collected in NPRA regarding COVID-19 vaccines. So this is the this. So far, we have cumulatively administered 68. This is overall, yeah. But later on, we will go to the kids statistics. So for overall, we have cumulatively administered over 68 million doses of vaccine COVID-19. And through MySejahtera, that is the number that we have received, notifications that we have received regarding AEFIs, which the rate is about 14,000 per million doses. And then we have another system, which is the NPRA ADR monitoring system for recipients or for our healthcare providers to report mainly serious adverse events or events which are not listed in MySejahtera. So for this one, the total reports that we have received just for COVID-19 vaccines, just for everyone's information, we also monitor adverse events as well as AEFI for other vaccines as well. So the total received for COVID-19 vaccines up to 25th March is 25,900, which is the reporting rate is 377, and 7% is actually just 7% is actually serious effects. So this is putting this overall picture in one infographic. So I just want to reiterate here that actually the percentage of serious report for all of these vaccines are quite similar among especially the main three vaccines that we use at the bottom there. And then it's actually very, very small in comparison to the total dose that we have administered. Right. So now we move on to children. So in comparisons to adults and adolescents, children reporting rate for AEFI COVID-19 vaccines is the lowest in children, as you can see there. The rate is 178, actually is 187 reports total, and only 9 per million doses are actually serious cases. Right. So this is the same thing in a more detailed form. So the total number of serious AEFI that we have received is 12. So I'd just like to compare these statistics with other countries. You know, people might be saying that, you know, probably we are not, you know, capturing enough. So when we compare it to other countries, NPRA does this very regularly, meaning that we look at our reference countries to look at what are the safety issues, what they are reporting, and so on. So if you compare to Australia, this is very similar to Australia, where their rate, reporting rate is about 150 cases per 1 million doses, as well as Canada will be a bit higher than us. All right, so if we zoom through what are being reported, especially for kids, for vaccines in children, which is Pfizer here. So the main things, the main effect being reported is fever, acute stress reaction, urticaria, vomiting, headache, shortness of breath, diarrhea, pruritus, and rash. So these are the top ones. So they are mild, very transient, and short-term effects. So if anyone is wondering what is acute stress reaction, this is just a slide to give you examples of what kind of acute stress reaction that we observe. Right? Okay, so now we go to serious events that were reported. So if you can recall, we only received 12 reports of serious events for kids with COVID-19. So basically, the rate is really low. And then we are also monitoring, as mentioned by Dr. Amar just now, we are also closely monitoring the risk that we know so far, which is four vaccines, Pfizer, which are anaphylaxis, myocarditis, pericarditis, as well as acute facial paralysis and thrombosis as well. So if we look at the distribution of this adverse events of special interest, or AESI, so overall, the first line there for anaphylaxis, overall cumulative case we received 68, and none of it is actually from big kids. And for myocarditis, pericarditis, we have observed 50, and only one observed in big kids. And acute facial paralysis, we observed 82, and 4 is from big kids. So we can see that the number is really low for all these AESIs that are being monitored. So even for overall, for adolescents and adults as well, the reports are also rare, very, very rare if we look at the common frequency range that I've mentioned in my previous slide. All right, so I would like to share this. This is from Australia's TGA website, whereby they have a sort of decision aid for parents when they want to compare, when they want to make risk comparisons between COVID-19 infection itself with the vaccination. I know Dato Amar had mentioned, had shared with us some of the weighing of these two benefit and risk. But here you can see clearly that on the left side there, on the red, which are in red, we can see the risk of COVID-19. People with COVID-19 to have all these symptoms is much higher than the symptoms, the symptoms, the mild symptoms that we observe with COVID-19 vaccination. And then the duration as well. I think that Dato Amar had mentioned earlier that for COVID-19 vaccines, you experience all these symptoms, even though some could be mild, but the symptoms will be prolonged. Whereas for vaccination, it will usually very transient, 1 to 3 days. And then this is another page. I just want to highlight here, like for example, just now inflammation of the heart, things like myocarditis. For COVID-19 vaccines, the risk is much higher, whereby in Malaysia, as you probably have realized, our rate is about 1 in a million, and then probably it can go up to 4 as reported in the UK, mentioned by Dato Amar. And then even for hospitalization, I mentioned the effects, the serious effects that we receive are mainly because they are hospitalized. So hospitalization for our population, when they take vaccine COVID-19, the risk is very low as compared to hospitalization with COVID. And for death as well, if we look so far, we have not, we do not have any death which can be causally linked to the vaccines as yet. But if our children get infected with COVID-19 vaccines, the risk for death is there, 2 in 1 million for which is reported in Australia. So yeah, I think so you can go. I've shared the link if anyone wants to go and have a look at this site. So so what to do if you suspect that your child has AEFI? So of course, go to the nearest health facility, get immediate treatment, and then get advice, and then your healthcare providers will help. They can help to report AEFI on your behalf, but you yourself also can report by going to our website, whereby we have a consumer reporting form. Our website is www.npra.gov.my. The consent form for consumers is a slightly different from the healthcare providers, but we encourage consumers to provide their clinical information as well when they submit the consent form. So if you are affected, severely or in a more moderate form, we would like you to recommend you to use the consent form rather than just MySejahtera, because if you realize in MySejahtera there are only a certain effects that you can report through a drop-down menu. So you need to use this consumer form to send to us. So if you're not comfortable to type online, a report online, which you can do, you can also print the form, fill it in manually, and then send us to that email at the bottom there. All right, so in summary, I just want to summarize what I have shared today. So one, all vaccines registered in Malaysia have undergone rigorous regulatory review to ensure quality, safety and efficacy of them. And vaccine safety is continuously monitored. So I want to assure everyone that we in KKM as well as NPRA are continuously monitoring the vaccines safety post-registration. As Dr. Amar had mentioned, things like to outweigh the risk. Or new information on safety get detected. So because we want all these safety issues are communicated quickly to minimize the impact of the risk. So I gave example just now, things like myocarditis was not actually detected during the clinical trials, but it was detected post-registration in other countries. So during post-marketing surveillance. So once it was detected, that's how we actually see on how the guidelines on how to manage this kind of effect in our clinical guidelines for COVID-19 vaccines. So that's what we do. So when we know the risk, we will know what to do, how to communicate to our healthcare professionals, to our public, or how to minimize the impact of these events. So based on our local data, I can summarize that the number of AEFI reported, especially in children, is very low, and the majority were non-serious reactions, for example, fever, acute stress reaction, injections, side pain, urticaria, and so on. And serious events are very, very rare. And then the reports that we see here is no different from what is being seen in other countries as well. So, and then it's also very important to remember that not all reported AEFIs, for example, those ones that you see in the statistics that I shared earlier, as well as probably the ones that you see people are talking about in social media, for example, are not necessarily causally linked to the vaccine. So some events, especially in adults, it could happen coincidentally. And our serious AEFI reports are thoroughly investigated and reviewed before causality is determined by an expert committee. So and then I've shared that vaccine recipients can also report. You don't have to wait for your healthcare professionals to report for you. The vaccine recipients can also report directly using the consent form that I have shared. So with that, I thank you. Thank you for listening. So I hope that clarify some of the doubts that we have about the risk of the vaccines. So thank you. Back to you, May.
Thank you for the very informative talk, Dr. Azuana. So participants, if you have any questions, please be reminded to post your questions in the chat box. All right, we will now move on to the Q&A session. All right, we have some questions collected during the registration. We'll first start with those questions. So our first question here will be for Dr. Amar. So what is the consequence of myocarditis? So how to treat this and how to treat this myocarditis?
Thank you very much. Could someone end that slideshow so that we could go back to a fuller view? Huh? And can you repeat the question again one more time? I apologize. Thank you.
What is the consequence of myocarditis and how do we treat it?
I think it depends whether you're dealing with myocarditis from the COVID-19 infection or you're dealing with myocarditis from the vaccination. So let me talk about the vaccination first. As we have Dr. Azuana and I both mentioned, it's an uncommon side effect. I think the highest rate is among teenagers and young adults rather than with young children. So far, the data suggests that the vast majority of these children, if not all of them, have recovered fully. So if you've got myocarditis, I think the key is to first detect it. As pediatricians, we will admit all these children to hospital, have them closely monitored. We want to rest them and then watch their recovery. And usually it's self-limiting. That means you recover yourself. I would like to say that we can reduce this risk. And the way to reduce the risk is before your vaccination, the day before your vaccination, rest. Tell your child to rest. And after the vaccination, the first week after the vaccination, don't do any exertion. Don't go and run around. Don't play on the trampoline. Don't go for a jog. Don't go for PJ. I think those kind of things are important. Occasionally when we've had a report, I saw one in Singapore. This adolescent went back to weightlifting after his vaccination, and then he had a nasty side effect. So I think don't stress your heart after the vaccination. Rest for a week at least. I think that's what to minimize your risk. But the first key is to keep an eye on symptoms as Ministry of Health guidance, and then secondly, say doctor, get admitted and just monitor. Usually no real treatment is required. Just rest in bed and monitoring the situation. If you got COVID-19 related myocarditis, then I think the risk is much higher for damage, for death, and we do not know what's going to happen long term to these arteries that are being damaged by the COVID. We worry that some of them may get a long-term damage. I'll stop there. Back to you, May.
Right. Thank you for the answer, Dr. Amar. What about for a kid that has COVID and post-COVID? So will Pfizer still be the best vaccine because of the risk of myocarditis in Pfizer?
I would like Dr. Azuana also to give an opinion on this, but let me start off first and say that, I think in our country, we're not taking enough attention to prior infections. I think there's good data now coming out about hybrid immunity. For example, if you've had 2 doses of the vaccination, then you get infected. Probably you don't need a booster anymore because that infection served as a booster. Okay, so in our country, we're not taking into account prior infections in our vaccination schedule. So I like to see more data on this. I think it's an area in evolution in terms of science. Perhaps if you've had a prior infection, maybe all you need is 1 dose rather than a full 2-dose vaccination. I'm a pragmatic person. I look at data. I don't think we just follow black and white schedule. Right now, the policy is that if you've recovered fully from a COVID-19 infection, that you get a 2-dose of a Pfizer infection. Of course, the Sinovac is also available to parents to vaccinate. In terms of a choice, I can't tell you which is better. I think Pfizer gives better protection than Sinovac from the data we have currently available. So I would recommend either of those vaccinations right now.
Okay,
Dr.
thanks, Amar.
Azuana.
Okay. For myocarditis risk, so far what we have seen, the effect is usually mild when it's caused by vaccination. So a lot of these patients have actually recovered. So a lot of times they were hospitalized, and the report is categorized as serious because they were hospitalized for observation. So a lot of times they have they recover. I think most of them have recovered. And then also the risk, we know the risks, and then we know which age group is affected most, as Dr. Amar had shared, mostly in young males. And then we know, when it can happen. So when we know all this risk, we are able to actually put in plans to mitigate this risk. That's why, it's there in the clinical guidelines, and then we also advise on, for those for the recipients, or for parents to observe their children. So when it comes to the question of whether it's CoronaVac or Pfizer, I think KKM had a very good reason to recommend Pfizer first, because we have more information on Pfizer vaccine, and then we also know the risk. So when we know the risk, it's very comfortable for us to make plans on how to mitigate this risk and actually reduce the impact. And then I think for myocarditis risk, we know that it happens very, very rare, and we know how and when it's going to happen. So so we can take precautions. So that's why probably KKM has chosen Pfizer first, and then but by all means, but if parents are more comfortable with CoronaVac, they can also opt for CoronaVac if they want.
All right, thanks, Dr. Azuana. So I guess that answers a bit of the question, like which brand of the vaccine will be related. Is it related to the safety of their use in children? Do you have anything to add on that? Like which brand is better for safety?
I think that what Dr. Azuana has said, what I said earlier, is true. We have an enormous amount of data on Pfizer. I suspect this is the most researched vaccine in the world ever. But for Sinovac, we don't have the same data. If you looked at Dr. Azuana's data, you can see the side effect rates were identical in two, although the public perception is that, Sinovac is safer than Pfizer, but the severe side effect rates were identical in both. So I think the public need to go away from this perception that Sinovac is safer than Pfizer. I think both vaccines have got some side effects. We don't have enough data on Sinovac. I wish we should push the countries that use a lot of Sinovac to publish data. But I think it's Malaysia who's doing some of this publication, and Chile is the other country. So again, as Dr. Azuana said, it's up to the parents to choose. I think in the end, we want you to be comfortable.
All right, thanks, Amar. So another question for Amar would be, how would you tackle the issue of a parent refusing to vaccinate their child, but their child expresses consent to be vaccinated?
Yeah, I think this is an issue that has been resolved in some countries because they have better legislation and better guidance for adolescents. That means they allow adolescents to make decisions. For example, in UK, there's something called a Gillick competency. Any child at 16 and above is considered competent to make their own health decisions. And they don't restrict that to only 16. As long as the doctor has a chat with a 12, 13-year-old, they know how to assess risk and benefit, they can make their own decisions. So both UK and US, for that matter, have allowed adolescents to get vaccination if their parents refuse, but they want, provided they're able to assess, they have the intellectual capacity to assess the situation. In Malaysia, we have no such legislation or guidance. Right now, the laws in our country say under 18 means child, full stop. Decision making is from your legal guardian, which usually is your parent. So we haven't fought these rights for our children. I think it's time that we fought for our children to have some rights. Right now, I would suggest that if a child wants and the parent doesn't want, ask his parent to come and speak to a pediatrician. Or maybe a MOH, vaccination site. Come there and have a chat and allow the child to express their desire, and the parents to express their concerns, and maybe the pediatrician or the MOH officer can act as a moderator to be an advocate for the child on behalf of the child. And that's one way to do this, but that's all that we can do. Right now, we still require legal consent from the parent.
Okay, thanks, Amar. The next question will be for Dr. Azuana. So, what are the effects of the vaccine on children with underlying epilepsy? Do you have any data on that?
Well, we do not have data on that, but yeah, effects of vaccines can happen to anybody. So it's very hard to tell who will get what. Seizures are also one of the effects that had been reported. So I'm not too sure whether the seizures that is being observed is because they have underlying seizures. So yeah, probably Dr. Amar can.
Yeah, I think the question, Dr. Azuana, is more, if my child has epilepsy, is it safe to vaccinate? Probably the question is more like that. In that case, I would refer you to MOH document. This is a priority child. It's considered a child with a chronic illness who is a higher risk from COVID, and I would vaccinate this child. I also want to point out that the Hong Kong data shows that BA2 is most damaging to the brain than other strains. And so you don't want your child's epilepsy to get worse. Better to get vaccinated than, end up getting a BA2 infection. Back to you, May.
All right, thank you for the answers. Okay, now this next question is for Amar. Okay, since COVID is now an endemic and many parents are positive for COVID, is it better to test the children for antibodies before we vaccinate them?
This is a very difficult question to answer. I don't have a black and white answer. There are studies ongoing. Right now, the guidance, for example, from the US CDC, is that antibody use is for research, for studies, not for routine use. And they don't recommend antibody use as a decision maker. Having said that, some doctors in Malaysia are using it. They test antibodies before they make a decision about vaccination. I also suggest the person who asks this question read some recent data on hybrid immunity, where prior infection, you still recommended to get vaccination because it reduces your long-term risk of COVID dramatically, and it's good to get vaccinated. So just because your antibodies are high doesn't mean I will not vaccinate you. I will still consider vaccination. Whether we give 1 or 2 doses, I think we need a lot more data right now. So I don't think we can go around testing antibodies for everyone before vaccination. It's too expensive. It doesn't make sense. We should go ahead with vaccination. But if you have a documented prior COVID infection, I think it's time for MOH to evolve their guidance and give guidance to people on the ground as to how to deal with that. Whether we need a booster, whether we give 2 doses, whether we give 1 dose. I think we need some thinking. Right now, I think there's not enough information in the world, which is why MOH has not come up with guidance. But I think we have so much change in the last 2 years in terms of COVID understanding. I expect some understanding of this in the next 2 to 3 months.
Yes, thank you. Amar, I agree on your answer. Okay, so now we have questions from the live questions that type in the chat box. So someone here asked that are adolescents going to receive their booster dose, as most of the adolescents are due for booster and there is no announcement from MOH yet?
Can't answer the question. I think MOH will watch data and watch what's happening in real world to our children before they make a decision. And there can be 3 decisions. 1, follow WHO and other guidance saying no need. 2, give only to high-risk children, the ones who are priority list, which means chronic illness and the rest. The 3rd one is give to everybody. So I think we cannot answer the question right now. Only I think the US has gone ahead. Most other countries have been conservative at the point. They're just waiting to see what is happening. Again, a new variant may come out and that may change our guidance completely.
Yes, totally. Yeah. So another question would be, any suggestions for children below 5 years old?
This is the crisis. I worry about these children. I don't know what to suggest except secondary measures. You see, vaccines are only part of the equation. We all talk about vaccines plus, okay, which means mask, ventilation, testing, working from home, reducing infections, and so on. So if my child is going to a kindergarten, which is the high risk thing for the 1 to 5, I would like to see every child who's there masked if they can. And I would like to provide them with FFP2 or KF94 masks, which are available for that size of children as well. Okay, these are comfortable masks to wear, by the way. They're not like the N95, which are very, hard to breathe. Secondly, I would work with the other parents, buy HEPA air purifiers, make sure I know the volume of air inside there, monitor what's happening with my CO2 in there, improve the quality there. Thirdly, I want to support the teachers and work with them very closely, offer testing so they can test more often. And the slightest time that one person is infected, that class shuts down so that everybody is protected. So I think things like this is what we need to do. It cannot be done alone. It has to be working with the other parents and the teachers in the class.
Yes, I think it will be a collaborative effort as well.
Yeah. May, can I suggest we go to the last question, which is very important, by Hugh Coffan. Are there any cases of severe AEFI causing death and disabilities reported?
Yeah, sure, you can go to the question first.
Or Dr. Azuana, yes.
Yeah.
Right. For overall reports, of course there are reports, because the way how people report is, if they have suspicion, meaning that, for example, if the event happened like a day or on the same day of the vaccination, so they will report. So if we're talking about a severe AEFI, causing death or disabilities, of course there are reports overall. For children, I have shared earlier, we have 12 reports. One actually is brought in that case, but when we look thoroughly at the early postmortem report, it's most like, because the child has a lot of underlying conditions, and the early postmortem report shows that the child could have succumbed to the complications of the underlying condition rather than vaccination. Right. So if causing, so far there is no death which can be causally linked to the vaccine, particularly for kids. For adults as well, we have about, in terms of reports, death reports suspected for any reasons caused by the vaccines. We have about 600 plus reports, but after presentation to the committee, so none of it can be causally linked to the death so far. Yeah.
Thank you for your answer, Dr. Azuana. I hope this clears your doubt.
Maybe a couple of, I'm sorry, I'm preempting you. There are a couple of group questions which are similar about when can I vaccinate my child after infection. So I'm just going to take them all one go. And Dr. Azuana, please chip in if you need to. So the three of them there, and one is very specific, the other two are a bit more. So again, I want to repeat what I said earlier, 2 weeks probably. MOH says when you're well after the infection, you can go. I would suggest 2 weeks, because 10 days to wash out the virus, and then give a couple of days after that, and then go and vaccinate, provided your child is fully well. But there is someone there saying, if my family member currently has COVID at home quarantine, is it safe to bring my children for the scheduled second dose vaccination, which is tomorrow? CSA says the kids with no symptoms can go to school, but self-test on day 1 and day 3. So I would like to say to you, if your family member is right now infected, your children are due for vaccination, don't go. My personal opinion, it's a personal opinion. I would say, they might get infected. With Omicron, almost everybody gets infected if you are proximity to each other. They may be asymptomatic. You don't want to go to a vaccination site and spread that bug, and you don't want to get a vaccine when you are having some other infection. You want to be fully well, even asymptomatic. So I would say wait 2 weeks, test your children, make sure they're negative, then go. That is a safer guidance for that situation. Even though I know the guidelines say you can go, I think that's a wiser thing to do. Dr. Azuana, anything to add to that specific one, where they ask this question, huh? Somebody infected right now and they want to go for vaccination. The children want to go for vaccination. Yeah. Any opinions?
No, I don't have anything to add.
Okay, all right. So that's just a personal opinion, I must say. Yeah. Okay. I'll give another personal opinion. Recently, the guidance was that after 5 days, you can go back to work. I think many of us are uncomfortable. The data suggests that 50% of people are still shedding virus at 5 days. So it's better to test before you go back, even though you're well. Huh? Our aim is not to spread the virus to other individuals. Even though you're vaccinated, you still have a risk of long COVID, and we don't want that risk to happen to anyone. Back to you, May.
All right, thank you for the answer, Amar. So another question here is, what are the guidelines or rulings regarding vaccinating a child turning 5 this year, but has not reached their birthday yet? Would PIC kids accept such a child?
Thanks, Bernice, for that question. And, in another talk that I had this week, somebody asked, can we vaccinate our dogs and cats, our pets? So obviously this is a country talking with excess vaccine. There is, vaccine needs in other parts of the world as well. I hope we will share. So coming back to children who are reaching 5, no, MOH is not going to vaccinate them until they reach 5. This is purely for safety reasons. We don't have enough data under 5 for Pfizer. Okay, for Sinovac, as I said, people are doing it in China and Chile, but we don't really have the phase 3 trials to look at for that age group to really show how effective or what we should do. Only phase 1 and phase 2. So I would say wait until 5. I know that, but Bernice is probably a parent who is concerned and wants to get her child vaccinated. I have parents with 2-3-year-old kids who want to get vaccinated right now because they know that that is the safest thing for the children, but we just don't have the data. As Dr. Azuana said, our NPRA is very strict. There's one thing you can trust pharmacists to be. Pharmacists are very meticulous and strict. They will make sure that things are safe before they let you have access to it. So I think wait until they have an opportunity to see the best data available and then make a decision. Definitely for Pfizer, we will need good phase 3 trials for young children. And I hope the same for Sinovac. Dr. Azuana, you want to say anything about this? Close to 5, but not yet 5.
Yep, yeah, agree with you. Because I think decisions made are based on evidence. So at the moment, we do not have enough evidence. So I think we just have to wait for it to come in. So, yep.
But it's worrying, isn't it? We see them dying. We see them having MISC, not in small numbers as well. And they are having the huge spike right now. So we don't know what's going to happen to them long term. So I hope that this evidence appears soon so we can make a decision. Somebody even asked in the questions, May, earlier questions, can I give my newborn baby vaccination? Definitely we will not. Okay. I think a newborn baby is somebody that we will need really, really good evidence. Huh? I know we give hepatitis B and BCG, but that has been tested for a very long time before we give it. So I think wait for more evidence. We probably will drop to 3 years old, but whether we drop below 2 is uncertain.
Okay, thank you for the answers, both Amar and Dr. Azuana. Okay, I guess that's all the time that we have for the questions and for the webinar as well. So ladies and gentlemen, we will now take a group photo. Can everyone please turn on your cameras?
Okay, try to switch on your camera. I will take a group photo right now, okay? So 1, 2, 3. One more time, 1, 2, 3. Okay, thank you everyone.
Thank you, Chloe. Okay, ladies and gentlemen, so that marks the end of the webinar. Thank you for joining us today, and I hope that you had a fruitful session. So on behalf of Taylor's University's School of Pharmacy, a very big thanks to Dato Dr. Amar-Singh and Dr. Azuana Ramli for their time and expertise on this topic. Have a good weekend, everyone.